So today we're going to talk about the antepartum hemorrhage. So first, all the slides and the presentation that I'm going to make for the whole OBGYN topics are going to be basically a combination of Gabby and Creasy and Williams and the ACOG guidelines and some from the Royal College guidelines. So let's start first with the antepartum hemorrhage. We all know that antepartum hemorrhage are mainly the placental abruption, subchorionic hemorrhage, placenta previa, vasa previa, and the PS or placenta accreta syndrome. So today we're going to talk about the placental abruption. So first, the obstetric hemorrhage in general is like one of the main causes of maternal mortality worldwide. And when I'm saying obstetric hemorrhage, I mean antepartum and postpartum hemorrhage. So let's first talk about the pregnancy-related hemodynamic changes. So what happens when women get pregnant? So imagine that you're like producing some kind of product and then you have at some point like increased demand, so you want to deliver more of these products to your consumers. So what you will do, you will first increase the production of, like, let's say you're producing mobile phones, so you're going to increase the production of the mobile phones, and then you're going to increase the number of vehicles carrying these vehicles to the consumers, and then you're going to try to empty the roads for them so they can arrive fast, and then you will try to make these vehicles as safe as possible so you can prevent the loss as much as you can. So when we try to apply this on the human body, it's basically the same. So usually the heart is used to like pumping certain amount of blood in non-pregnant females, and then once they get pregnant, then you will have an increased demand. So to meet this demand, first, as you say, you're going to increase the production. So you're going to increase the red cell mass, it's almost by 20 to 30%, and then you're going to increase the plasma volume by 40 to 50%. Okay, remember the vehicles. And what I'm saying here, you will notice that the volume expansion is more than the red cell mass. That's why pregnant women will have physiological anemia. And then you need to increase the production itself. So the cardiac output is going to increase by 30 to 50%. The cardiac output is basically the stroke volume multiplied by the heart rate. So by increasing the heart rate and stroke volume, the cardiac output is going to increase. And then you're going to decrease the systemic vascular resistance. You're going to peripheral vasodilation. So you're going to increase the decrease the systemic vascular resistance to allow more blood to flow to the organs. And then as a safety, the pregnancy is like a procoagulant state. So almost all the clotting factors increase except for factor 11 and 13. And this is to control obstetric hemorrhage. So this is like a safety thing. So these are basically the main hemodynamic changes that are going to occur with the pregnancy. So now we're going to talk about the maternal adaptation to hemorrhage. So what's going to happen if pregnant women starts to bleed? So the first 10% that the women are going to lose from their circulatory blood, basically the body is going to take care of it. So the physiological adaptation is basically the body is going to say, so I'll redistribute the blood to go to the most important organs, which are the brain, heart, and adrenals, and it's going to switch it away from the less important organs. So you're going to have arterial and venous vasoconstriction to prevent the blood from going, or like slow the blood going to these organs, and then redistribute the blood mainly to the organs that I just mentioned. And this is going to maintain the blood pressure and blood flow to the essential organs. So basically, nothing major is gonna happen. But then if this bleeding continues and then no replacement or nothing's been done, so what's gonna happen that more than 20% of when you lose more than 20% of the circulatory blood volume, so this physiological adaptation mechanism are going to fail. So the blood pressure is going to start dropping, the heart rate is going to start increasing, and then this is going to lead to poor end organ perfusion and organ failure and shock. So the classification of hemorrhage. So we have four classes of hemorrhage. The first class, when you lose around 10 to 15% of the blood volume, which is like almost 1 liter, what's going to happen, as we say, physiological adaptation. So nothing major is going to happen, just palpitations, dizziness, nothing major. And then at 1.5 liters, which is like 20 to 25% of the blood volume, you're going to start having tachycardia, tachypnea, and then normal pulse pressure. So why normal pulse pressure? So pulse pressure is the difference between the systolic and the diastolic pressures. So the systolic blood pressure is basically depending on the stroke volume, which is unchanged. But the diastolic blood volume is basically based on the systemic vascular resistance. That's going to increase because we said peripheral vasoconstriction will increase the systemic vascular resistance. So this is going to narrow the pulse pressure. At 2 liters, which is almost 30 to 35% of the total blood volume, you're going to have more tachycardia, which can reach like 120 to 160 beats per minute, and tachypnea, which can reach like 30 to 50 per minute, breath per minute. And you're going to have cool extremities. And then after that, the patients, when the blood loss goes beyond 2,500, it's like almost 40%, then you're going to start having hemorrhagic shock and oliguria, and eventually, if the patient is not treated, she's going to die. So let's first talk about the abruption. So first, what's meant by abruption? Where is this? Where did this name came from? So abruption means break off. So it's like placenta is breaking off. Okay. So let's talk about first the definition, and then see what we need to, what criteria do we need to fit in this definition. So in a simple way, placental abruption, as we say, placenta is breaking off, so it's like a separation of the placenta, but it's not just any separation. So it's a premature separation. So premature means that between 20 weeks gestation, because before that, that's a different scenario, okay? So it's like between 20 weeks gestation, okay? And before delivery of the fetus, because if the placenta is separated during delivery, that's not considered an abnormal thing. With delivery, the placenta should separate after the delivery of the fetus. So that's the first thing, premature separation. And this separation can be total or it can be partial. And then this placenta has to be normally implanted. And this is very important to exclude placenta previa. You cannot have placenta previa and abruption at the same time, because placenta previa is like a different thing that's associated also with antepartum bleeding that we're going to talk about next time. But now we're talking about the placenta previa, so about the placental abruption. So you have to have a normally implanted placenta, and then you will have a partial or total separation of this placenta. And as we said, it's premature, so it's between 20 weeks gestation and delivery. So when we talk about incidence, it almost occurs like complicates 1% of the pregnancies. That's like the overall incidence. And it's responsible for 1/3 of all the antepartum hemorrhage together, as we say. we have other causes for the antepartum hemorrhage that we mentioned earlier. And then it mostly occurs in the third trimester before 37 weeks. So what's the pathogenesis behind that? So I will say it's bleeding between the decidua bisalis and the placenta. So this will dissect the decidua apart, leaving like a thin layer adherent to the myotonia. So basically the placenta is from like the chorion, which is the fetal part, and then the decidua, which is the maternal part. So when you have the bleeding, you're gonna start dissecting the decidua, leaving it attached to the myometrium, and then start separating the placenta. That's exactly what happens. So what are the underlying events? So why did this happen? Different causes. Maybe the commonest is just rupture of the decidual spiral artery. So we all know the blood supply is going to be the uterine artery, and then the branching will go to the arcuate arteries, and then the radial arteries, and then the spiral arteries, and then these are the terminal branches. So when you have bleeding from the spiral arteries, this is going to cause hematomas, and as I said, either like which is the placental abruption. And then the second thing that might happen is vasospasm in the abnormal maternal arterioles. The third thing can happen is just venous hemorrhage. So sometimes when you have like thrombosis in the placental vessels, going to be necrotic areas, this area is going to have venous bleeding in it. Less commonly is going to be like a disruption of the fetal placental vessels. And the acute shearing forces also. This is an important mechanism during a motor vehicle accident. So with the sudden, with the, the acceleration, deceleration process, the shearing forces can cause placental abruption. The last thing is just the sudden decompression of an overdistended uterus. And I'm talking about like patients with twins, patients with polyhydramnios. So the sudden decompression can also cause placental abruption. So the progress. So what's going to happen after the placenta is separated? So either it's like a self-limited, you'll have some separation, then it's going to stop, or it's going to progress and further dissect the decidua. And if it kept going, then we have a problem. So we basically classify the abruption into two types. The first type, which is the overt or the revealed abruption, and the second is the concealed abruption. So the revealed, let's say that you have the placental abruption, you have the bleeding, and then this bleeding is coming out, so you can see it's coming out from the cervix and the vagina, so you can see it. So now that's what we call overt or revealed abruption. But the other option is just concealed. So let's say the blood is being collected behind the placenta and it's not coming out. So if this blood is not coming out, so that's a concealed bleeding. So what's the problem? Still we didn't say like the placenta is separating. Okay, that's fine. We say revealed, concealed. Again, what's the problem with the placenta separation? So you have three major problems. The first thing, you're going to lose the placental function. So if you lost the placental function, what's going to happen? That the baby is going to start to struggle. So fetal hypoxia, acidemia, and eventually fetal death. For the mom, with this bleeding, if the bleeding kept going, so eventually it's going to end up with hemorrhagic shock. And then, as we know, when you start to have bleeding, too much bleeding, then the coagulation cascade is going to start, but it's not going to stop the bleeding. So the bleeding is going to keep going, and going to be consumptive coagulopathy, or like DNC. DIC. And then the third thing that can happen is the Cuvier uterus. So Cuvier is just, it's named after the French physician Alexander Cuvier. He first described it in 1912, if I remember correctly, and it's just named after him. So it's basically blood escaping into the myometrium. So we all know that the bleeding from the placental side is going to stop by the myometrial fibers contracting around like in a tourniquet mechanism, like the tourniquet fashion around the spiral arterioles. So with blood inside the myometrium, so the myometrium is not going to be able to contract properly, which can predispose to atony and postpartum bleeding. So what are the risk factors for the abruption? So the first thing, most of the topics, when we talk about like what are the risk factors, you say the previous same condition. So previous abruption or history of abruption is going to be one of the major risk factors. So with one previous abruption, the incidence is going to be 5 to 10, the recurrence risk is going to be 5 to 10%. With two abruptions, the recurrence is going to be 20 to 25%. And then the intrinsic maternal factors like advanced maternal age, higher parity. The African Americans are a higher risk of having fetal death secondary to the abruption, which means that we're not saying that the placental abruption per se is more common in the African Americans, but we're saying that the placental abruption that's severe enough to cause fetal death is most common or more common in the African Americans. Then we're going to talk about the substance use. So the most preventable risk factor for abruption is smoking. So smoking cigarettes is a major risk factor. And it's dose dependent. So there is like a linear relationship between the smoking and abruption. So let's say if a woman is smoking one pack a day, this means that her risk of having abruption is almost 40%, which is like very high risk. The second thing is like the cocaine and methamphetamines. As we know, the cocaine is going to cause vasoconstriction in the placental vessels, causing decidual ischemia and eventually abruption. The other cause of the other risk factor is the trauma. So, as you say, trauma, mainly the two common traumas, two common causes for the trauma are like domestic violence and the motor vehicle accidents. So with the motor vehicle accidents, there are three mechanisms. Either it's like a direct placental injury, so it's like a penetration, direct penetration injury, or it's like thermouterine stretch, or the placental shearing that we say from acceleration, deceleration forces. Other risk factors are the maternal diseases. So maternal disease like hypertension, hypothyroidism, asthma, all this stuff. The PPROM, the preterm premature rupture of membranes. So the placental abruption complicates 2 to 5% of all the cases of PPROM, especially if there's like a chorioamnitis or oligohydramnios. But the question I cannot answer if it's a result or a cause, because it can go either way. So when you have placental abruption, the bleeding and the consumption coagulopathy, you're going to have thrombin. So the thrombin production from the abruption is going to stimulate the cytokines and the proteases that are going to break the membranes, and PPROM is going to happen. And it goes all the way around. So we can also say that the PPROM with rupture of membranes, cytokines and proteases are going to be released, and they're going to damage the decidual vasculature, causing the placental abruption. So the vasculature the decidual vasculature is going to be damaged from the protease and the cytokines. So it's hard to tell if it's like a cause or result. We obviously don't know. Then we have the rapid decompression that we mentioned with the over-distended uterus, like the twins. Like after the delivery of the first twin, there is a risk of placental abruption, because we said you cannot have this after delivery of the second twin, because that's normal. And with the polyhydramnios, with the spontaneous rupture membranes, or during therapeutic amniocentesis, like when you're trying to do therapeutic, not with the diagnostic, because it's not going to cause sudden decompression. Unless PPROM happened, that's a different scenario. The other factors that can predispose to the abruption are like some uterine factors, like the uterine anomalous, synechia, fibroids, especially if they're like submucosal or something, or like behind the placental implantation site, the cesarean score, some placental factors like the abnormal placenta, like the circumvallate placenta, for example, or the chronic placental ischemia, like with the preeclampsia and the fetal growth restriction. Some fetal factors like the isolated single umbilical artery, or like some major fetal congenital malformations also can predispose to the abruption. So let's start the clinical thing. So how do we diagnose patients with placental abruption? So we have to mention that the diagnosis of placental abruption is clinical. So it's a clinical diagnosis. You can always confirm your diagnosis with like imaging, labs, the cardiotocography, pathology, all this stuff can help you with establishing the diagnosis. But at the end, abruption is a clinical diagnosis. So how do we diagnose it? First, we have to know that, and always put this in the back of your mind, that you have 4 different presentations. You can have like an acute bleeding, overt abruption, or you can have concealed abruption, or you can have chronic abruption, or like some atypical presentations. So the acute abruption, basically we're talking about vaginal bleeding, pain, contractions. That's it. This is the typical presentation. And any patient, any pregnant patient who is presenting with bleeding, you should always suspect placental abruption, especially if there's like a trauma or anything like that. You always suspect placental abruption, because when we talk about topics that needs to be diagnosed clinically, you have to always have high index of suspicion. Like you have to always have this diagnosis in your mind so you can diagnose it as quick as possible. So let's talk first about the bleeding. So you can have mild bleeding, you can have severe bleeding, but mild bleeding does not mean that you have a mild abruption, and severe bleeding does not mean that you have more severe than the mild one, because you can have mild vaginal bleeding. So the patient is presenting with like mild vaginal bleeding, and then there's like a lot of blood collected behind the placenta inside and it's not showing. So this is a severe abruption with mild vaginal bleeding. So it does not correlate. The second thing is abdominal pain. The patient is going to present with abdominal pain. It's more important the concealed, because with the revealed, you're going to have the bleeding, but still they will have abdominal pain. And then contractions. So with the contractions, typically these contractions are going to be high in frequency and low in amplitude. So they shouldn't stimulate labor, but they can stimulate labor. But as I will say, the commonest shape for these contractions is going to be high frequency, low amplitude. And then the second type is the concealed. So with the concealed abruption, patients are going to may have the pain and tenderness. And the problem with the conceals is, first, because of the hematoma is going to increase the intervillous pressure, the pressure inside the placental vessels. So it's going to push more thromboplastin inside the large veins that are draining the placenta. So basically, it's pushing more thromboplastin in the maternal circulation that's going to cause consumptive coagulopathy, or DIC. The second problem with the concealed is that because you don't have bleeding, so the diagnosis might be delayed. And if you have a delayed diagnosis, you're going to have poor outcomes. You're going to have poor outcomes, of course, with something like that. So with ongoing bleeding, the presentation is going to start to change. So the patient is going to present with more uterine tenderness. They can start to have tachysystole. The uterus is going to be contracting too often. You're going to have abnormal fetal heart rate patterns. And then, as we say, DIC, and the hemodynamical stability is going to be borderline, and then she's going to be hemodynamically unstable, and then eventually she might die and the baby might die. With the chronic abruption, the patient is going to mainly present with light intermittent bleeding, and they might present with signs of placental dysfunction, like the fetus growth restriction, preterm labor, PPROM, preeclampsia, and something called CAOS, like a chronic abruption oligohydramnios sequence. So it's like an oligohydramnios, as we mentioned before, because of the abruption, and it's not because of PPROM. Then with the atypical presentation, some patients, when they have a posterior placenta and then you have the abruption, they will just, the only presenting symptom is going to be severe back pain, and that can be tricky. And one of the tricks that you can do to diagnose these patients, just when you press on their bellies, the pain is going to be worsened by that, because you're basically compressing the fetus against the placenta, which is going to cause more pain. So you compress her belly, she's going to have more pain. And as we said, you have to always have a high index of suspicion to diagnose these patients. Then you can use your other tools to help you establish diagnosis. So the imaging, we have the ultrasound and the MRI. So the ultrasound is an integral part in evaluating these patients. But this does not mean that it's sensitive. It's not, because 50% of the abruptions are not gonna be associated with any abnormal findings, because this might be early, you might have revealed bleeding. It's like a lot of stuff. So it's not sensitive. So if you found abruption, that's fine. So the patient, you confirm the diagnosis. If not, this does not exclude that the patient might be having placental abruption. The other thing that the ultrasound is going to help you with is to exclude placenta previa, because as I said, any patient with antepartum bleeding, you have to exclude the placenta previa that we're going to talk about next time. When you're looking for the abruption, I'm not going to go too deep ultrasound details, but we're basically looking for the extent and size of the abruption. And the other thing that you're looking for is the location of the abruption. So the main three locations that you can have abruption in, to basically, to simplify things, we have the chorion or the fetal part of the placenta, and then we have the membranes, and we have the decidua, which is the maternal part of the placenta, and then we have the myometrium. So if you have bleeding between the placenta and the membranes, this is called subchorionic hemorrhage. If you have bleeding between the placenta and the myometrium, which is basically behind the placenta, so it's called retroplacental bleeding, which is associated with higher fetal mortality rates than the subchorionic. And then if you have a bleeding between the placenta and the amniotic fluid, so that's called preplacental. Okay. The MRI is not commonly used, and it's just reserved for the patients where you cannot diagnose the abruption, but you don't know, and the ultrasound is equivocal, so you cannot actually tell. So in this situation, you can use the MRI. The other things that can help you are the labs. So two types of labs. You have the initial assessment labs and you have predictive labs. So when I'm talking about the predictive labs, I'm talking about labs that are studied to see if they can predict if the patient is going to have placental abruption at some point of pregnancy, which means that you don't do this in acute settings. These are labs that will be done in the first trimester or whatever, just trying to predict the abruption. So back to the initial assessment lab. So when you have a patient with abruption, you think about what you want to exclude, what's going to help you. So the patient is bleeding. So if the patient is bleeding, you need hemoglobin, hematocrit, you need platelet counts, and you need type and screen, type and cross. You need metabolic profile, liver functions, kidney functions, so you can assess all this stuff. And then you will need the KB test, of course, for the Rh negative woman. You're going to give them the RhoGAM anyways, but you need the KB test to see if they need an extra dose. And you're going to do a urine toxicology screen so you can basically see if it's like secondary to cocaine or something like that. So that's because the patient is bleeding. So the other concern is the DIC. So you will have to send fibrinogen, coagulation studies, all the stuff, so you can exclude the DIC or diagnose it if it's there. When it comes to the predictive labs, so there is no enough evidence to support the routine use of this stuff, but I'm just mentioning the stuff that was studied. So some studies state that unexplained elevations in the maternal serum alpha-fetoproteins or HCG or like decrease placental associated plasma protein A or unconjugate estriol, any change in the inhibin A, decrease or increase, all the stuff can be associated with or like predictive of placental abruption. With the NIPT also, the cell-free fetal DNA, sometimes you get a report saying that low fetal fraction. This might be associated with obesity, might be a lot of stuff, but they say that it can predict placental abruption also. The other thing, it's not laboratory though, but sometimes you can do uterine artery Doppler after 24 weeks, and then you're going to find like a notch. It's like ultrasonic finding. We don't have to go into details, but some studies say that if you have this notch, this means that these patients are at a high risk of having fetal growth restriction, preeclampsia, and placental abruption. The other thing that will help you, and this is actually an integral part, is the CTG. So you need to monitor the contractions because, as we say, patients might have contractions, and since they are low in amplitude, you might miss them. They might not be like clinically appreciated, but you will notice them by using the CTG. The second thing is just the fetal monitoring. because you can actually have abnormal fetal heart rate patterns with the placental abruption. The last thing that can help you when you send the placenta to pathology, they're gonna have like a macroscopic picture, a microscopic picture, and then eventually gonna diagnose the placental abruption. So now let's talk about the pregnancy outcomes. So what are the outcomes? So it's like maternal and fetal, and they all make sense. I mean, patient is bleeding, so acute blood loss, blood transfusion, DIC in 10%, and organ damage, because this is an acute and emergency situation, so higher incidence of cesarean deliveries and peripartum hysterectomies because of the atony and the associated blood loss, and then eventually death. For the baby, it's the same. Hypoxemia, acidemia, oligohydramnios, as we mentioned, with the chronic abruption, fetal growth restriction, stillbirth, and the prenatal death is like raised tenfold. Now, the most important part. So, how do we manage patients with placental abruption? So, actually, nobody can tell you how to manage because it's a clinical judge. Like you have to use your judgment. What we're going to discuss now is just like I think this is the best approach to manage a patient with placental abruption, but you have to put in your mind that the management itself, the management decision, the clinical management decision is going to vary based on the severity of the abruption, the fetal status, the maternal status, the gestational age, like a bunch of stuff. So, with the OB patients, you're basically dealing with two patients, not one, because you have the mom and the baby. So, the first thing that I think you should do is just to see if the baby is alive or dead. So if the baby is dead, so you're just dealing with one patient. If the baby is alive, so you're dealing with two patients. And then after that, you have to assess the maternal stability, see if the patient is hemodynamically stable or no. Does she had a DIC or no? And again, when I'm saying, because we are presenting and writing stuff, so we say first you do the assess if the baby is dead or not, and then second you assess for the maternal. But usually everything has to be done simultaneously, like this is an emergency situation. So when we diagnose the fetal death, you have to do like an ultrasound. Like you cannot diagnose a fetal death just by the CTG, because sometimes the electrodes, when you put it on a dead fetus, it's going to transmit the maternal pulsations, and you can think that the baby is alive but just distressed. So it has to be an ultrasound. So let's say we have a dead fetus. So with the dead fetus, so we just have one patient now, right? So let's see if this patient is stable or unstable. If the patient is stable, so okay. So I have a stable mom, the baby is dead, so we don't have to worry about this part. So what you need to do is close monitoring for the hemodynamical status, because she might crash at any point. And the second thing, we have to send like a serial lab, check for the coagulopathies, all this stuff. And eventually you need to deliver this patient. So the vaginal delivery is going to be the preferred route of delivery because the patient is stable. On the other hand, if the patient is unstable, so the first thing you need to do is to stabilize this patient, like the regular resuscitation stuff and replacement and all these things. And then you will need to expedite this delivery because the mom is unstable. So if you have like an imminent vaginal delivery, you can go for vaginal delivery. If not, you will go for a C-section. And again, as we say, like a different things can affect your management. The patient is going to get better. The replacement and resuscitation is going to work. So she's going to be stable now. I'm not talking about, I'm just talking in general. And as we said, you have to use your clinical judgment. But in general, unstable patients, um you have to expedite delivery, is like imminent vaginal delivery, or you go for a C-section. And when you're assessing the stability of the patient, you have to put in your mind that patients who have preeclampsia, which is a common association, right? Preeclampsia and abruption, she might be hypertensive, but still hemodynamically unstable because she's originally hypertensive. So you have to use the rest of the stuff, the urine output, capillary fill, heart rate, all this stuff. Because if you rate just on the blood pressure, um, you're gonna have like a full sense of security that the patient is stable and she's not. The second thing, if the baby is alive. So if the baby is alive, as we say, the next thing you do is you check if the mom is stable or not. If the patient is unstable, now you have to do the triaging part. You have baby and you have an unstable mom. You don't have to assess the fetal status right now, because when you have an unstable mom, you have to expedite delivery. So you stabilize the mom, and then unless you have imminent vaginal delivery, you go for a C-section for maternal indication, which means that you're going to do the C-section regardless of the fetal status and regardless of the gestational age, because this is a C-section for maternal reason. It's not for fetal reason, right? The second option, that if the baby is alive and the mom is stable. If the baby is alive and the mom is stable, now we can assess the fetal status and see if the baby is category 3. So eventually you're gonna do, again, expedite delivery. If the baby is like imminent vaginal delivery, that's fine. If not, you'll go for a cesarean delivery for like, now it's a fetal indication. If the baby is category 2, so now you have to use the resuscitative measures and see, you have to deliver the patient, but like you go vaginal or C-section is gonna depend on the clinical setting itself. And if the baby is category 1, so now the baby is stable, the mom is stable, so now we can base our management based on the gestational age, because now it's not an emergency situation. So first, where we are going to manage this patient. So in general, if you have a patient who is bleeding, and you diagnose placental abruption, you will have to admit this patient to the hospital at least 48 hours. And if they're gonna go home, they have to stay bleeding free for 48 hours at least. So patients who are asymptomatic from the start, like in a different scenario, you can manage them outpatient, provided that they are like well educated, they have emergency transportation and all this stuff. But in general, you will manage these patients in the hospital. What you're going to do, monitor the maternal status, monitor the coagulopathy, so clotting, the coagulation profiles. You monitor the vitals, you monitor her status, you monitor the baby, antenatal testing, the non-stress tests, all this stuff. And then you give steroids for lung maturity. And if the baby is less than, if you're anticipating delivery before 32 weeks, you will give magnesium for neuroprotection. And if this patient develop some contractions, it's debatable either to give like tocolysis or no. So that's a debatable part. So we're not gonna go talk about what you should do, because we obviously don't know enough evidence to support. Some books are going to say, yeah, you can give tocolysis. Others are going to say, no, don't give tocolysis. And eventually the end point is going to be 37 weeks. So if the patient made it to 37 weeks, you're going to just deliver her. And as we say, if there are no obstetric indication, you can always go for a vaginal delivery. If the patient is between 34 weeks and 36 weeks of gestation, so now you will basically do the same thing: admit the patients, antenatal testing, monitor her vitals, coagulation profile, steroids, but you're obviously not going to give magnesium at this point. And then if at any point the patient deteriorated or anything happened, you're going to obviously go to the beginning of the algorithm and see and manage accordingly, and deliver the patient. If the patient presented after 36 weeks, she's stable, the baby is stable, as we say, but she's like more than 36 weeks, so usually you're going to deliver this patient. Like, you don't have to wait. Then let's talk about the intrapartum management. So how do we manage a patient who's having abruption and we are trying to deliver? So we said that induction and like augmentation, they are not contraindicated, and the vaginal delivery is not contraindicated. The induction and augmentation, they are not contraindicated during the placental abruption. So how do you manage labor? So first, for the maternal surveillance, so what you'll need to do, you will need to monitor the vitals, serial coagulation profiles, the same thing that we're seeing. Okay, because you need to detect if there is like any hemodynamic instability early. For the baby, you'll have obviously do continuous monitoring. Preferably, you're going to use the IUPC and FSE so you can get like a better assessment. For the labor management though, so we say previously that the uterus is going to be hypertonic. So the hypertonicity, this can cause like the labor might go fast because of this hypertonicity. But this also can cause more fetal distress because um, of the back-to-back contractions. The second thing is the early amniotomy. So there are like pros and cons for that. So when you do the early amniotomy, the first benefit is going to be that, you remember when you say the consumption coagulopathy is going to happen because the retroplacental hematoma is like increasing the pressure, increasing the pressure into interfili. So when you do the early amniotomy, you're just relieving this pressure. The second thing that you're going to benefit from the early amniotomy is just it's going to fasten the delivery, right? The disadvantage of that is like an infection. I'm just talking about something specific here. So usually if the baby is small and the head is not compressing the cervix and you broke the patient's water, so the progress is it's not gonna be the same, because the best dilator for the cervix is always the fetal head or the presenting part. The second best dilator for the cervix is the bulging bag. So when you break it, you're going to lose this part. So what about the Pitocin? So you can use Pitocin provided that the patient is not in tachysystole, because we say tachysystole is common. So you're using your IPC, you're using your monitors. If the patient is not contracting enough, you can always use the Pitocin to augment and get her delivered. For the cytotag though, the misoprostol, so it's not favored when it comes to the induction of these patients because, as we know, it's associated with tachysystole. The oxytocin can cause tachysystole also, but you have control over it. You can stop it, and then 5 minutes, and that's the effect is gonna go away. That's the half-life. But with the cytotag, you don't have control over it. You just, once you put the cytotag and you have tachysystole, it's gonna be a problem. With the route of delivery, as we said, we go for vaginal delivery. It's not an emergency. I don't want to say mostly, but like in a lot of times, you're gonna have to go for operative delivery because of like the maternal distress or fetal distress, just to shorten the second stage of labor. For the C-sections, though, I said it's gonna be an emergency situation. So decision to delivery time is to be less than 20 minutes. It's just that C-section, and as we mentioned before, you might have the cochlear uterus. So when you find the cochlear uterus, you know that this patient is at risk of having postpartum hemorrhage. So you have to check with the bleeding and make sure you give uterotonics and manage accordingly. So that's it for the placental abruption. So we're gonna talk briefly about the subchorionic hemorrhage, and the reason I put here because I don't want anybody to be confused between the subchorionic hemorrhage and the placental abruption because that's a different entity. So the subchorionic hemorrhage is basically pooling of blood between the uterine wall and the chorion. The incidence is around like 4%. And basic diagnosis is like if you have a small subchorionic hemorrhage, it's going to be incidental finding during the first trimester ultrasound. We don't have to worry about it. We just monitor. Otherwise, if it's like a large subchorionic hemorrhage, patients can have bleeding in the first half of the pregnancy. They can have abdominal pain. They can go into like threatened miscarriage or preterm labor. What we basically do is just like monitor the mother, monitor the baby, serial ultrasound. They do growth ultrasounds later in the third trimester, and actually you don't need to keep doing like a serial measurement of the dimensions of the subchorionic hemorrhage because it's not gonna change your management because you there's no specific management for this condition. Like you're not gonna go deliver the patient based on that. So if the investigation is not gonna change your management plan or your diagnosis, so obviously no need to do it. So you just do the serial ultrasound, just to like a growth ultrasound at the third trimester, just to make sure the baby is growing fine. You do the antenatal testing, that's fine, but nothing more than that. And although there is no enough evidence to support the routine use of that, but it's suggested that you do cervical length examination measurement. So when you examine the cervical length, if it's like a short cervix, you have high risk of preterm going into preterm labor. When it comes to the pregnancy outcome, they are generally good. Like mostly everything's gonna be fine. The baby's gonna be fine. The mom is gonna be fine. However, still associated with a high risk of placental abruption, preterm delivery, spontaneous abortion, and stillbirth. I'm done, and these are, as we said, mainly Gabby and Creasy and Williams. And thanks. Next time we're gonna talk about the placenta prefix.